Hi class, welcome to the online session. We are going to discuss on 5 slides for today. We have slide 21, that's thrombosis, followed by slide 16, necrotizing vasculitis, slide 211, temporal arthritis, slide 76, cystic medial necrosis, and slide 147, aortic dissection. So we'll start with thrombosis. So we have taken thrombosis during the hemodynamic disorders chapter, and we have learned that for thrombosis to occur, there should be the presence of 3 characteristic abnormalities, which we would call as the virtuous triad. So first, we should have an endothelial injury. So there should be an injury to the endothelial lining. And then this is accompanied by stasis of the blood flow. And lastly is hypercoagulability of the blood. So for thrombosis to occur, all 3 should be present. Okay? So in the slide, we would see 3 tissues. Okay, we have this one would be the center, and the thrombus formation would mean that there would be the presence of partial or total obstruction of the lumen of the artery, which in this case, this is a total obstruction or obliteration. This is characterized by the deposition of fibrin and platelet, which would correspond to the pale areas, and then you have the red blood cells, which would correspond to the darker areas. Okay. So again, this would be the lighter areas, which would be composed of the fibrin and platelets, and the darker areas corresponding to the red blood cells. The alternating pale and dark areas would be referred to as the lines of Zahn. Okay, so this is a new thrombus. Okay, and this is characterized by the presence of the lines of Zahn. We would also see the presence of lipid deposition. Okay, so notice the presence of these slit-like structures. These are what we call as the cholesterol clefts, CLFETS. Okay, so these areas would contain lipid. So thrombosis would be accompanied by lipid deposition. Also seen in this particular tissue would be the presence of calcification at the medial portion, which is what we call as the Monckeberg sclerosis or calcific medial sclerosis. It would mean that this patient is already an older individual. Now we go to the one on the left side. This is another form of thrombus. You can see this is the lumen, intended lumen. There will be a thrombus formation over this portion, leaving behind this area for the lumen. Okay, so this is an old thrombus because there's already organization. Okay, when you say organization, it means that there's the formation of fibrosis, and very important would be the recanalization. When there's recanalization, there's already the formation of new endothelial lining. Okay, so this signifies an old thrombus. The lines of Zahn can still be identified. Okay, so presence of lighter area and darker areas, fibrin and red blood cells. You would still be able to identify the presence of these cholesterol clefts, and then you have presence of some macrophages. Okay, so these are lipid-laden macrophages and some red blood cells and fibrin. Okay. And then we go to the other area. this is another thrombus. It's still an old thrombus. Okay, so you can see the presence. This would be the lumen. There's the presence of recanalization on this portion. You can see the presence of small vessel lumen or lumina. Okay, and this would indicate presence of recanalization. The rest of the areas would be similar to the other old thrombus. And you can also identify for the presence of the Monckeberg sclerosis or the calcific medial sclerosis. Okay, now let's go to the next slide, which is slide 16. This is called necrotizing vasculitis. So this is a skin slide, okay, wherein we would see the presence of some inflammatory cells. These are segmenters. Okay, so necrotizing vasculitis, it can be infectious or non-infectious in origin. When it's non-infectious, it can be due to the presence of antibodies, circulating antibodies, like the ANCA, anti-neutrophil cytoplasmic antibodies, the presence of anti-endothelial antibodies, the presence of anti-autoreactive T cells. It can also be the presence of infectious agents, what we call as the infectious vasculitis, like the presence of bacteria, fungal organisms, and other infectious causes. So we look at this particular area wherein we would see the presence of small blood vessels there. Okay, so the blood vessels here would show the presence of inflammatory cells around it, the presence of fibrinoid necrosis. So this would show the presence of fibrinoid necrosis, which can be seen with necrotizing vasculitis. So again, presence of inflammatory cells, segmenters, and fibrinoid necrosis. Okay, let us try to look for another one. Although in this case, this is only showing the presence of perivasculitis. Okay, so this is well-formed arteriole, okay, surrounded by segmenters. Okay, so in the biopsy, usually we call this one as perivasculitis. And then you would see the presence of intraluminal inflammatory cells. Okay, so this is slide 16. Next, we go to slide 211. This is temporal arthritis. Okay, so this is a slightly faint stain. Okay, and it shows to you the temporal artery. So this is a temporal artery tissue. This is also called giant cell arteritis or temporal arteritis. Take note when you are going to diagnose this one, this is only seen in older individuals aged 50 and above, and they would be identified with fever, fatigue, and weight loss, which are non-constitutional symptoms. But in addition to the temporal artery being involved, it can also involve other blood vessels like the vertebral arteries as well as the ophthalmic artery. That's why these patients can sometimes present with blindness. Okay, so it's a T-cell mediated immune response, and what we would see here would be the presence of intima thickening. So high power magnification. Okay, let's try to see. This would be the tunica intima. Let's look at that. Okay, tunica intima. We have the tunica media, and then you have the adventitia. Okay, the tunica intima is thickened. So there's intima thickening, leading to the presence of a slit-like lumen. Okay, slit-like lumen. The intima would show the presence of a chronic granulomatous inflammation. characterized by the presence of these macrophages, and some T cells. So we have a chronic granulomatous inflammation, and it's not clear here, but there would be the presence of fragmentation of the elastic lamina. This would be in this area. So again, presence of inflammatory cells. These are macrophages because it's a granuloma. So these are epithelioid histiocytes accompanied by lymphocytes. So this is temporal arthritis. Okay. Next slide is 76. This is what we call as the cystic medial necrosis. So cystic medial necrosis, this is from the aorta. Okay, so this is aorta, and what you would see here is the presence of loss of smooth muscle and deposition of connective tissue. The common culprit here would be hypertension. With hypertension, it will result to vasoconstriction of the vessels found in the vasa vasorum over this portion, and it will lead to medial ischemia. Okay, so the ischemia here will lead to the deposition of amorphous material. So look at this portion. You can see some blue tinge of the area. Okay, so there is the separation of the smooth muscle fibers. The spaces here, the cystic spaces, are filled with amorphous ground substance, which would be called the glycosaminoglycan. Okay, so again, the pathogenesis here is usually hypertension with myocardial ischemia caused by the because of the vasoconstriction of the blood vessels found in the vasa vasorum, and would lead to deposition. Okay, there would be loss of smooth muscle fibers and deposition of and synthesis of non-collagenous extracellular matrix, which we would call as glycosaminoglycan. Okay. And our last slide for this session would be slide 147, which is aortic dissection. So aortic dissection can be, it would be a medical emergency, a surgical emergency, and this would be caused by the presence of an intimal tear. So this is the original lumen of the aorta. Okay. And you can see here the presence of a tear. At the, there would be an intimal tear, and it will lead to the accumulation of blood into the tear. Sometimes it ruptures, producing a hematoma. Okay. And sometimes it can be lucky, it produces another intimal tear, causing what they call as a double barrel aorta. There are two groups that can be susceptible to an aortic dissection. Number one would be 40 to 60 age bracket with history of hypertension, and then the other one would be connective tissue disease seen in younger individuals with example would be Marfan syndrome, and lastly it can be iatrogenic due to a coronary bypass or manipulation. Okay, so those are the slides that we are going to talk about for today's session. Stay safe and good night.